very great to see everybody, and it's an honor today to speak to you about brachytherapy. It is my favorite thing to speak about and a treatment that I really believe in strongly. Can everyone see my slides okay before we get started? Any issues with the visibility at all? Okay. So without further ado, let's go ahead and get started. So today we are going to speak about, just try to minimize my camera. There we go. Today we're going to speak about a lot of stuff. It is very hard to do a talk about brachytherapy nursing in 1 hour because there's so many components of it. And I can talk about it for an entire course of lectures. So I tried to pull what I felt would be the most valuable for this course to introduce what brachytherapy is and how it benefits people with cancer or even some benign growths. I want to explain the difference between two commonly used types of brachytherapy, high dose rate or HDR and low dose rate or LDR. And then I also want to discuss how it's delivered to patients, whether it's through seeds, which is LDR, we'll get to that, or through applicators or implants or needles. I also want to explain the key aspects of providing nursing care for a patient with an HDR brachytherapy applicator or needles from the day of implant to discharge. And a lot of this lecture will focus on gynecologic HDR because it's the most common and, in my opinion, one of the most needed types of brachytherapy. We will also review basic concepts of patient education and then learn about further resources and further courses coming up on brachytherapy. So the first section will be Introduction to Brachytherapy Concepts. The first poll question is here. I want to know, for those in attendance, if you have at your institution brachytherapy, and if so, what type? The options are 1, none, 2, I don't know, 3, GYN, 4, prostate, 5, skin, 6, breast, or 7, other. All right, so the results are 31% have no brachytherapy, 6% say I don't know, and that's okay. Brachytherapy is a very specialized form of treatment. 57% say GYN, which, like we said, is one of the most common uses of this, especially worldwide. Prostate, skin, and breast. Prostate 16%, skin and breast 8%. All right. Also, the next poll question, how would you fill in this statement? I have blank knowledge of brachytherapy. Option 1 is 0, 2 is minimal, 3 is moderate, and 4 is extensive or expert level.
And I feel that the number of respondents regarding which disease site from the last question is pretty concordant with, I think, what we also sometimes see in the States. GYN tends to be the most common, and prostate has a lot of good literature for as well. I feel that maybe skin and breast, not every center does, but there's a good few expertise institutions that will perform those disease site brachytherapy as well. Okay, let's end this poll, and we got 58 respondents here. Let's see what the results show.
All right, so 19% say 0 knowledge of brachytherapy, 29% say minimal, 52% moderate, and 0% say extensive. So we have a wide amount of experience here, and I think today's lecture will have something for everybody. Okay, without further ado, we'll get started. What is brachytherapy? Brachytherapy is the delivery of radiation using sealed sources that are placed as close as possible to the site to be treated, often internally within a tumor, surgical bed, or an anatomical area. It can often be described as internal radiation, but it's not always internal. But a lot of people think of this as radiation from the inside, and we'll explain some of the exceptions to that. External beam is radiation going from the outside into the body through targeted beams. This is radiation going directly to the source and treating directly where it needs to go. Again, the two main types of brachytherapy that are used today, the most common are HDR and LDR. And these can be used to treat conditions from head to toe, but the main focus again today will be the GYN HDR brachytherapy or pelvic brachytherapy, which we care for the patients very similarly, prostate, GYN. But because GYN HDR is the most commonly practiced, we will have a heavy focus on that. Brachytherapy has actually been around for a long time. It has morphed over the years of how it's used and the research and the technology, but it's been around over 125 years at this point, or 124. And HDR came about, I want to say, in the 90s, roughly 90s. One of my colleagues who's now retired was one of the grandfathers of HDR brachytherapy, Dr. Jeffrey DeMonis, and LDR is still practiced as well. So LDR brachytherapy is the older type, but it is still current and it is still a great treatment. It is where a radioactive seed itself is implanted permanently into a target or a bunch of seeds. For example, for prostate cancer, many radioactive seeds will be implanted directly where they need to go, and they will give off radiation over time directly in the tumor or in the tumor bed. And then after a while, they become inactive and they're just permanent seeds that don't have any more radiation after however much duration. Radiation precautions are needed for a short duration, but we find that the instructions do vary by institution and region of the world, but usually there is some radiation precautions that do need to be taken, both for staff and for patients. And again, this is commonly used for prostate cancer. The only place in my practice that we do this is for eye melanomas and eye plaques. The rest of what we do is HDR, and this talk will focus on HDR. So HDR brachytherapy is brachytherapy that is delivered directly into tissues or tumor via plastic or metal needles, different types of applicators or superficial molds. And the radiation will be delivered by a machine called an afterloader, which is a radiation machine that will be connected to the applicator or needles or mold, and will deliver radiation directly to the area with the use of one small seed. It's different types of sources. We use uridium-192, and it will travel along and dwell at various points in each catheter or needle or part of the applicator to deliver how much radiation is needed, millimeter by millimeter. It's pretty amazing, and it's completely customized to the patient. The types of HDR brachytherapy, there's four big categories. Interstitial, which is when the needles go through tissues, through the tissues themselves. It's invasive. Intracavitary, where an applicator goes into an existing body cavity, such as breast or vagina, and we'll show some photos of that. Intraluminal, where the applicator will go into an existing lumen, such as into the endobronchial brachytherapy. And then topical or superficial, such as skin, and we'll show a few examples of that. All right, last poll question for now. If your institution performs brachytherapy, do you use LDR or HDR? Or both?
All right, and we launched that poll, and so the way I know Kayla was I was a fellow at UCLA, and I learned from her and some of the other physicians there, and became proficient in HDR brachytherapy. But at KU, we also use LDR, and we treat we treat prostate cancer with LDR, and we have a relatively high volume LDR practice as well. And like Kayla said, it is definitely a treatment modality that is still highly prevalent in the States. That said, I do think that HDR is rising quite a lot, and many institutions are using HDR more, primarily because of what Kayla described as that customizable radiation dose that can come with HDR. And truly, I don't think there's a better radiation modality that can create a more conformal treatment than HDR. Okay, so we have this poll here. I'm going to go ahead and end it, and let's share the results.
All right, so we have 56% responding HDR, 15% LDR, and 29% offering both. So again, good mix of experience of people on this on today's call. So for the purpose again today, we will focus on high dose rate brachytherapy with an emphasis on GYN. So how is HDR brachytherapy customized? The magic happens once the needles or the applicator is in where it needs to go. That is where the physicist and the physician and dosimetrists, and also in some parts of the world, RTTs, have this role of creating this customized treatment plan. And what happens is they can program how much radiation will go through each part of the needles or the applicator, and they can target exactly what they want with a very high dose And then they can contour out and spare the urethra, the rectum, different parts of the body to minimize dose there or have dose be within an okay amount. There are constraints that they have to follow. But this is where physicists, physicians, dosimetrists, and at times RTTs come together and create this customized treatment plan. The first step, they have to have the procedure done where this stuff is put in. The next step, which we'll talk about, is some sort of imaging that they use to create this plan, whether it's 2D or 3D. We'll get into that. Then the computer work happens where they create this customized dose. The area of red is a very high dose. This is a prostate implant. And then as the circles go out, this is my non-physicist brain explaining it. I'm obviously not a physicist, but as those rings go out to the yellow and the green, and Dr. Shao actually might be able to tell more than me, it's less and less dose. And all of the doses you can see is highly concentrated in the middle. And all of those blue dots are the needles. And Dr. Shao, anything from a physician standpoint you'd like to add further on the meaning of the light blue, the yellow, the green?
Yeah, that's a very good question. So, I presume everyone on this chat treats with external beam, and the difference between external beam and our internal radiation is the radiation has to come in from the outside to get to the target. Um, but we think that the heterogeneity that comes with brachy, meaning that that radiation source being placed directly into the target, allows us to dose escalate to the tumor, and there's also that really quick fall off of the radiation to the nearby structures. So these different isodose lines, I don't know what dose they represent, but I presume what we see here is that in the lines that are close to the needles, like the yellow circle around each needle, that's probably 200% isodose to your prescription. So heated up quite a lot right at the level of the needle, and then as you see the different colors, it's probably at 100%, 90%, 80%, 70%, and it drops off really quickly. And then you see in this prostate image, the urethra down the middle, you can see that the colors spare that specifically to minimize some of the urination side effects that can come from our treatment. And then you can also see the rectum in the back there in the pink and the pink contour, and you can see that a lot of the isodose lines are also falling off quite a bit to that structure. So yeah, so that's why I think HDR with that customizability is really important. The aspect that as a physician we always have to think about though is that the radiation source can only travel where you put your needle. So if you don't have a needle there, you can't treat it. So when we do our implants, we have to be very careful in thinking what is the plan going to look like once this is all said and done? Because if we only put the needles halfway through the prostate, then we can't treat the other half. So it requires a lot of expertise and collaboration and multidisciplinary care, including nursing and physicists and dosimetrists, just to make sure we deliver a good plan.
All right. Thank you for letting me call on you. I have a nurse brain. He has a physician brain. As long as he can answer a couple questions for me that I can't explain quite as much as I want to, we're good. So radiation treatment plans, again, this is a different type of applicator. This is a type of intracavitary GYN applicator. This is done with the use of imaging. So again, the needles or the brachytherapy applicator is put in, usually in the operating OR or the theater, as they say a lot outside of the United States, at times with sedation or anesthesia. And then imaging is obtained, which is 2D, which is usually X-ray or fluoroscopy, or 3D, which is CT or MRI, or ultrasound-based, such as with ultrasound-based prostate treatment. So interstitial HDR brachytherapy. Right now I want to talk about interstitial. So common body sites for interstitial is the pelvis, by far the most common, prostate, gynecologic, so uterus, cervix, vagina, even vulvar cancers, rectum. These, again, from a nursing standpoint, there are variations, but they also are cared for very similarly. So I kind of group them together as pelvic implants. There's breast interstitial brachytherapy at some centers. Also, some centers will do head and neck for recurrent head and neck cancers, base of tongue. Really, if you can get the needles in, you can treat just about anything. Lymph nodes is one of my favorite ones that we do with the guidance of interventional radiology. We can treat within the lung, within the kidneys, but we need the help of interventional radiology to safely get the needles there. Very few centers in the world offer that. I'm just showing that if you can get a needle into things and you have the right infrastructure and support from other disciplines, really brachytherapy can be used to treat a lot. But for most places, it is pelvic, GYN, with a heavy emphasis on GYN. Lung and esophagus, limbs and skin, we can treat anywhere with interstitial HDR brachytherapy. The number of treatments, the number of delivery of treatments that goes through those tubes depends on what we're treating, what's in the literature, so the body site, also the stage of the disease and what other concurrent treatments they are getting, such as chemo or external beam, and of course, the availability of resources. Some centers, especially in areas where patients have to travel very far, a lot of the centers I've been working with throughout Africa, I know patients come from sometimes even other countries because they don't have brachytherapy where they are. And so their fractionation sometimes will be dependent on, it's a mix of literature as well as what resources are there, how long can the patient be there, do you give it in 2 fractions, 3 fractions, 4. So you will see variability based on team, region of the world, and what is being treated. This is an example of a very large GYN implant that we did. This is most of these cases are from my team, not all of them, but some of them are just standard brachytherapy stock photos. But this was one of Dr. Demonis's implants. This was a very large gynecologic tumor, interstitial implant. All of those white tubes are the plastic needles, and they are going directly into where treatment needs to be given. The green tube is a tandem that's going up through the cervix and delivers treatment up into the start of the uterus as well. Other examples of interstitial brachytherapy, again, if you can get the tubes where they need to go, you can treat a lot of things. The one on the right is our most common prostate. That's prostate HDR, and you can actually see the white tubes are what connect the patient to the afterloader. The one in the middle was actually a case we just did about a month and a half ago for a recurrent tumor in a young man's kind of by his sacrum. And it was palliative. He had already had surgery, external beam many times for various parts of this. Was a mass with many portions and spread. And so we did brachytherapy for palliation, and that was a really neat implant through his glute. And then you can see head and neck brachytherapy as well, and you can treat directly to tumors that way. So types of intracavitary brachytherapy. So the emphasis here is the cavity. This is where a applicator will go into an existing cavity, and very commonly it's used for gynecologic cancers, especially for cervix. There's different types on the left-hand group of pictures. The one that is the long tube, that is a multi-channel vaginal cylinder where patients walk in, walk out. They put this in with a little bit of lubricant or lidocaine jelly, and they get treated just in the vagina. Or the one on the left with the circle around it on the far left, that is a applicator that has a ring. And then on the bottom is tandem and ovoids, where basically the dose goes up into the tandem, which goes up into the cervix, and then those ovoids will spread open, and basically they can distribute the dose a little bit differently. The ones with tandems, those are a little bit more uncomfortable to place. So usually, although not always, centers practicing this will have some sort of sedation or pain control. On the right is a breast intracavitary. It's not as common in a lot of centers. We don't do too many of these anymore. But if a patient had a recent lumpectomy and there's an existing cavity, there are applicators that you can actually put in to that existing cavity and treat brachytherapy that way. So again, to highlight GYN, there are 3 main versions and considerations: interstitial needles, tandem and ovoid or ring, and then vaginal cylinder. Anytime from a nursing standpoint that there's interstitial needles, this is where there's going to need to be pain control, usually anesthesia or sedation, depending on what resources are available. There's a higher chance for vaginal bleeding when these get taken out. And these are used for tumors that are larger or have extension beyond what, say, a vaginal cylinder can reach by itself. This also, from a nursing care standpoint, I include hybrid applicators with needles in this because needles in the tissues are one nursing category, whether it is an intracavitary applicator with a couple needles, it's called a hybrid, or if it's a big interstitial implant, from a nursing standpoint, we will care for them the same way. Tandem and ovoid or ring, these patients usually require some sedation or pain control, but not at the level of interstitial needles often. Nursing care is similar to that of an interstitial patient, but the patient's stay may be shorter, not always. And then vaginal cylinder, these patients rarely require sedation unless they have severe stenosis or very painful insertion. But because it's not puncturing the tissues, this treatment, the vaginal cylinder treatment, is very well tolerated by most patients, and they walk in and walk out. And the nursing care is a little bit less intensive because their risk of bleeding is less, although not zero. And their need for pain meds is much less, but they still need support, especially emotional support. So vaginal cylinder, you can see again, same concept as what we showed for the prostate implant. You can see the dosing, it goes directly where they want to have it. And we're able to deliver a very high targeted dose directly to the tumor while sparing the surrounding structures, such as the bladder, which you can see in yellow, that blue tube and the blue, or the circle up in the bladder is the Foley balloon. And then red, of course, is the rectum, the dark red there. And the treatment is the purple and the red right there in the middle. So again, just to summarize, you can, this on the left is a breast implant, on the right is that glute case that I showed from a couple months ago. You can put treatment directly where you want it if the physicians can get the needles where they need to be. So like we like to say, if we can get a needle into it, we can treat it. And needles are not the only way to get to these tumors. Again, there's applicators, but needles are powerful with brachytherapy, and a lot of areas are really trying to see how far we can go with this, such as into the lung and into other areas. In very few centers, but I want to get the point across of how amazing and capable brachytherapy is. But the core of what we really need to do to reach people right now is to treat gynecologic cancer, and especially cervical cancer. That if that was available to patients worldwide, the world would be such a better place, and brachytherapy makes all the difference for those patients. So skin brachytherapy is much more straightforward. It can be delivered topically via an existing pre-made applicator like the metal one on top, or with a mold if we need to kind of wrap around parts of the body like the ear. In this case, it was a patient we were treating the shin. And same concept. This will attach to the afterloader and it will treat radiation, but it'll just be on the surface of the skin. Nursing care for these patients is very similar to external beam. It's radiation skin care. Protect the skin from the sun and friction. Don't pick at it. If it does start to react, we will do site care if we need to, and applying the protective moisturizers free from alcohol or scents. And then of course, monitoring for signs of infection, especially on the lower extremities. That can be a little bit more prone to getting infected, and we have to be very careful. But otherwise, nursing care for these patients, it's a lot of education and just support. Examples of intraluminal, this is not super common, but since we're talking about interstitial, superficial, and intracavitary, I don't want to leave out one example of intraluminal, or two, such as endobronchial, where we take a very thin catheter that goes down into the bronchioles wherever it needs to be treated, and it will attach to the afterloader, which you can see there, the behind the person with the purple gloves, you can see the machine. That is the catheter being attached to the afterloader, and that will deliver the radiation through that tube. And then on the right, it's an example of a non-cancerous condition that brachytherapy can help with, which is cardiac intracoronary brachytherapy. It can actually help prevent stent restenosis, and some centers are starting to do this as well. So an interesting non-cancerous reason for brachytherapy. So treatment goals for brachytherapy, it is often curative, but it depends what we're treating. It can still have a positive impact on patients, even if we can't cure them, such as in palliative cases. The goals of treatment will depend on the pathology, the tumor type, the presence of metastases, and concurrent or previous treatments. It can be highly curative, especially for prostate and a lot of gynecologic cancers, a lot of skin cancers. It's a very good curative method. Local control is when we want to try to keep the cancer, treat locally, prevent future spread. And then palliation, of course, is palliation, such as for pain control or bleeding, or to try to just keep it as small as possible, but it still can improve quality of life, especially in the gynecologic patients. As everybody probably knows on this call, gynecologic cancers can bleed a lot. And these women, especially with advanced cancers, can spend a lot of time going to the hospital, getting blood transfusion, and just losing a lot of blood. And radiation, even if we can't cure that cancer in a palliative setting, we can still, radiation really improves bleeding in particular and very quickly. So we can make it where we can treat this tumor, make it bleed less, hopefully shrink it down and improve their quality of life and have them at home more than at the hospital. So for brachytherapy nursing and bedside care, what do we do as brachytherapy nurses? This is a question that when I first started in brachytherapy nursing in 2012, I had no idea what it would become, all of the potential with brachytherapy nursing. There is so much that I have learned. And I came in as a very experienced nurse. I came in from trauma ICU and I could take care of very sick patients. And I had no idea how much I still had to learn about nursing and what nurses could do that brachytherapy taught me. So I really enjoy talking about brachytherapy as a specialty. So brachytherapy, starting as a new nurse in brachytherapy or starting a brachytherapy program, it can be overwhelming, but it's a really neat thing. Challenges will always present opportunity for professional and personal growth. For example, brachytherapy nurses are often radiation oncology nurses that now have to learn how to do procedures and provide perioperative care or anesthesia care, or how to do disinfection or sterilization, care coordination. There's all these layers that we expand our skills when radiation oncology departments start brachytherapy. Brachytherapy nurses, we have to be experts, and this depends on the setup of your institution, but a lot of us have operating rooms in our department. So we have to become experts not only in outpatient nursing, bedside nursing, but pre-op, intra-op, post-op, outpatient care, sedation, navigation. There's so many different areas where it's like a melting pot of nursing specialties in one area. And it's a lot to learn, but your skills become so high. And that's why I get really excited about it. Many nurses also will have external beam responsibilities at the same time. So trying to figure out how do I balance this is always interesting. And then of course, flexibility, self-discipline. If there's something I don't know about the OR, I don't work, I didn't used to work in the OR. I went and I found resources online. I taught myself how to do it. Having that autonomy is to learn and find resources on what you need to succeed. It requires autonomy and discipline for sure. Resilience and communication. The physicians, the physicists, the RTTs, this is so much a team treatment and department. Brachytherapy teams, we really depend on each other and we're always talking to each other because we each have a critical role in every single brachytherapy patient, and all of us need to come together to be able to complete one treatment. Brachytherapy nursing is a specialty. There's no perfect guide for how to be a brachytherapy nurse because every team and facility is somewhat different, but our core needs are the same. I have been traveling extensively working with brachytherapy teams all over the world. And even though we all have our own variations of how we do certain things, our needs, our questions, and we have the same needs, and that's what we are starting to build and discuss and network over, such as pain control, bleeding management, care navigation, all of that stuff. It doesn't change in the world. What changes is your OR in your department? Is it in the hospital? What treatments do you deliver? Do you have access to anesthesia? Those are the things that do vary. So we try to give general guidance to different groups, zeroing in on the really important things like pain management, bleeding control, bedside care, side effect management, And then we can network and collaborate on these bigger logistical things. Historically, few resources have existed on providing bedside nursing care for brachytherapy patients, but this is what we are actively growing in the last couple of years, and it has exploded on a global level, and it's very exciting, and it's been very fun to be a part of that. So brachytherapy nurses, again, it varies by institution, but we are involved in everything: patient care coordination and preparation, pre-operative care on the day of procedure, actually getting them ready for anesthesia if they're getting anesthesia, putting the IV in, explaining, teaching, intraoperative care if the procedure's in your department, actually assisting the physician, assisting anesthesia, handling supplies. Post-operative care, if the patient received anesthesia, we are often the ones recovering them, though sometimes facilities have special dedicated nurses for that. Sterile processing or cleaning, high-level disinfection, equipment management, direct bedside care, and of course, patient education. The list goes on, but we're busy. A really neat aspect of brachytherapy nursing is it is never boring. You have so many areas in so many areas of the hospital. Procedural nursing is someone's job. Assisting with anesthesia intraoperatively is someone's job. Bedside care, inpatient, another job. Working in the clinic, another job. Care navigation, another job. And we get to do everything. So it sounds overwhelming, but to me, it's fun. And it keeps all areas of our nursing brains active and engaged. So the typical flow for our patients, again, will be the day of the procedure. They'll have their implant or applicator or needles, whatever version you're using, at times under sedation or anesthesia. They'll have that put in. Then they will do the stimulation, again, 2D or 3D, to start that planning. The treatment calculations will be done by physics, the physician, and the rest of the team. And then the HDR brachytherapy treatment will be delivered by the remote afterloader. The number of treatments will vary, as previously discussed, depending on what we are treating. And the implant, applicators, or needles will be removed after the final treatment's done. They will either go home or go to the hospital for further stay if they need more treatments with the same applicator or needles. So for some concrete brachytherapy nursing skills, again, I've emphasized this will be mostly for GYN and some prostate, just due to how much time we have today and how vast these treatments are. Most important thing for HDR brachytherapy, no radiation precautions are needed. These patients are not radioactive after their treatment. And this is something that a lot of people are very afraid to be around our patients because they don't know if they're radioactive or not. These are HDR patients. LDR patients, which again, focus of this is HDR, LDR patients do have some radiation precautions, and that will vary by institution and radiation safety officers. For HDR brachytherapy, there are no radiation precautions once the treatment is done. And all radiation actually occurs when they are in the treatment vault, attached to the machine with the machine on and all of us outside of the room. That is when they're being treated. And as soon as that machine turns off and the source goes back into the machine, all radiation is gone. We do not have to handle their bodily fluids or their waste in any special way. This is not like chemo or like theranostics or other types of radiation. And there's no risk for patients to be with family or pregnant people or children during their hospital stay or after discharge. A lot of confusion exists about this. So for HDR brachytherapy, they are not radioactive. For positioning, for pelvic brachy, this is GYN and prostate or rectal even. Patients typically require strict flat bed rest with the head of bed less than 10 degrees or on one pillow. The reason for that is these catheters or these needles are up in their pelvis, and if we bend them, it will adjust the positioning and potentially damage their organs or damage the implant or hurt the patient. So we keep them in a very strict flat bed rest. And then depending on the physician's preferences, I've worked with different doctors, different teams, and they all have some version of this. But when there's a pelvic implant, the common ones that we see are supine positioning with legs up on pillows, taking care to avoid pressure on the implant, applicator, or needles. I just went down to Colombia, and in Colombia, they use this really nice hip abductor wedge, and that's how they kept their patients' legs away. Others use pillows. Teams get creative with this. They have the physicians each seem to have their preference. For another common positioning is keeping patients in stirrups, especially if they're only getting one treatment. Some physicians do choose to keep their patients' legs up in stirrups for the treatment, especially like for ultrasound-based prostate treatment, when they really don't want the implant to move at all. That's another variation as well. So nursing care, from a diet standpoint, if they have a pelvic implant, we generally will place them on a low fiber or low residue diet to minimize chance of bowel movements for obvious reasons. Other physicians may order a clear diet or even keep them NPO. I have worked with teams that I've seen all of those. If it's a low fiber diet, it's limiting intake of fresh fruits, vegetables, coffee, beans, or legumes. For GYN patients in particular, they seem to be a little bit more prone to diarrhea because they've often had recent chemotherapy, recent external beam, and also the combination of that with IV antibiotics. Sometimes they get diarrhea no matter what we do. And we do the best that we can to shield the implant, but it is tricky when they have bowel movements with these in place. Most of our patients do a bowel prep of some sort. I've only seen one center that did not require bowel prep for their gynecologic patients, and that helps clear the rectum, but it doesn't fully clear the whole gut. So there is still a chance of bowel movements, though they're very rare with a good bowel prep, a low fiber diet, and minimizing treatment time. Jay, you have your hand up.
Yeah, I just had a curious question. So first, I want to emphasize how important Kayla's work has been, and I think what you'll notice is that, as she has said, there is no standardized nursing brachytherapy curriculum that exists. Most nurses, probably a lot of the folks on this call, have had no prior radiation oncology training before they enter radiation oncology. And even specifically brachytherapy, there's just no curriculum. So her work in this space has been really important to try to educate nurses and their roles and better prepare them for the difficulty and complexity that comes with nursing care and brachytherapy. And what I wanted to ask here, I struggle with this for some of my patients, and I'm curious from a nursing perspective what you do. Sometimes with the more complex interstitial GYN cases that we keep overnight for a few days, um, it's hard because they're lying in bed in stirrups or legs separated, flat for 3 days, and we try to limit their diet because we don't want them to stool onto the applicator. So um, I forget at UCLA and also what have you seen that has been helpful to prevent prevent any kind of damage to the applicators, but also making sure that the patients that are lying flat and not moving stay well nutritioned in the time that they have in the hospital. You mentioned clear diet over here. There's probably also some additional IV fluids that you can give for hydration. But yeah, what is your typical advice in that situation for interstitial GYN patients that have to stay in the hospital for a few days?
Yeah, so we will put them on a low fiber diet, but we always tell them you have to be able to, whatever you order, you have to be able to have it laying flat. So that often leads them to order broth or things with straws that they can drink while flat. I find most of these patients are not very hungry. And I think it's a side effect of the narcotic pain meds, that, from the medications themselves, their appetites are usually not very high. And when they do eat, we have these restrictions, and usually by the time that we're done, they haven't had time to fully form stools. Now, we do have patients that have diarrhea, and the way that our physicians anchor these implants, we do allow for repositioning every 2 hours, but this is a highly controversial thing around the world. Some physicians do not want their patients moved at all, but once they're in the hospital for 3 days, there will be a bad bed sore occurring if we don't, especially on larger patients, which a lot of these patients have some body mass to them. And so for those patients, we anchor these implants with sutures, and the needles themselves are very fixed. We do a scan every morning to make sure they haven't moved. And if they have, we can adjust back to make sure we're right on target. But we always will anchor it well. So if they do have to have a bowel movement, we can get them on their side, shield the implant, and have them go in a bedpan. And that seems to work most of the time. But the diet itself is tricky, but most of these patients are not very hungry. And if they do have a bowel movement, we deal with it, but it's usually diarrhea. It's never a form stool. We also do a pretty good bowel prep as well. They drink stuff to kind of clear them out from the top, and then they do an enema. So they come to us quite empty. But if we deal with bowel movements, it's usually diarrhea.
Thanks. Yeah, that makes sense. And yeah, the movement aspect we worry about too, because we have had nurses in the hospital that have rolled the patient and our
Mhm.
applicator has moved, which is concerning from a radiation delivery standpoint, but also laying flat the whole time is not ideal for the patients too. So that's
Yeah.
definitely a point of controversy.
Yeah, skin breakdown has and will happen, and it's a mixture of securing it well and training the inpatient units, which is a talk in itself. How to care for our patients. We did a whole quality project on that and published that back in 2017. There's so much opportunity for nurses to be educators, not just for their team or internationally, but for the hospital staff as well. So for pelvic brachytherapy, the other thing we have to be really careful of and watch for as nurses, if there's an interstitial implant in the pelvis, the patients are at risk for hematuria. We see this the most in our prostate patients, just with the proximity of the prostate to the bladder, but also in the gynecologic patients, you can see it, especially if they have bladder involvement of their tumor. So nurses just need to watch for hematuria development. If it happens, you and your physician will have a agreed upon protocol. For us, we have orders to go ahead and just manually irrigate ourselves as nurses. Some facilities, the physician or even a urologist will get involved. But the important thing is to watch for it, alert your team if it happens, and have a plan for how to prevent clots forming in the bladder. And then nursing care for a non-pelvic implant, it's case by case basis. It depends what we're treating. Brachytherapy nurses often have to be very creative in how to care for patients with unique implants, such as this very unique implant, which was a 17-year-old who had a sarcoma in his foot. He refused amputation, which was the recommended treatment. So he got external beam with a brachytherapy boost. That was a really amazing implant done by Dr. Mitch Kamrava. For this patient, obviously he had unique orders: bed rest, but he could sit up because it was his foot, but he couldn't walk on it; site care to take care of it, make sure it wasn't oozing, and he obviously could eat a normal diet. So it just depends on what we're treating. This is where teamwork and communication, collaboration, we get creative. We have orders with our physician, and we make sure that we teach the inpatient nurses as well. So from a pain management standpoint, this is one of the most common things that nurses around the world have questions about. And it depends what pain medications that they have access to. Some radiation oncology units do not have pain medication. Other ones have everything they could possibly need. So it's evaluating what you have. What we recommend is narcotic or opioid pain medication for interstitial implants, especially. There's long-acting ones, there's short-acting ones. The nurses can decide with the physician what the patient's needs are. Do they need a quick dose of, for example, fentanyl to take the needles out and then it wears off quick and they leave? Or are they going to be in bed for several hours and need something a little bit longer acting, such as hydromorphone? Use of non-narcotics or non-opioids is important too, such as acetaminophen, or outside the US, it's called paracetamol in a lot of places, or benzodiazepine, or also NSAIDs, but you do have to be careful with those if hematuria is present. Some facilities have access to epidurals or spinal anesthesia, and those are very effective for the pelvic population. Or nerve blocks are even practiced, such as a pudendal block or a paracervical block, to provide really good localized nerve pain control. And then, of course, nursing 101, non-pharmacologic pain methods, music, spirituality, humor, visitors, relaxation techniques. These are very real. Warm packs to the low back or to the abdomen, especially in our gynecologic patients. They will get abdominal cramping that they describe as being like menstrual cramps. As most people with a uterus know, menstrual cramps are a very different type of pain, and they respond well to heat, and they respond well to NSAIDs, better than opioids. And so nurses can get very skilled in identifying what type of pain they're having and have these different things that you can try: a little bit of this, a little bit of heat, a little bit of, relaxation, and some opioid to try to target pain from different angles, not just one big dose of a pain medication. Dr. Shao, your hand's up again.
Yeah, Navuga Maria has a good question in the chat that she asked that I wanted to bring up here. So she asked if antibiotics and chemotherapy can lead to diarrhea, how can sepsis be dealt with in case it happens for GYN patients? And I can't say that, at least personally in my practice, that sepsis has happened quite often. But we are really worried about that possibility with chemotherapy, given that their immune system is low. So, Kayla, yeah, do you have an answer to that question? And then I also have maybe an answer of my own too.
I do. And I might take us over on time because I have a lot of slides, but these are really good questions. So I think we need to address this question now because it's very important, and we'll cover it a little bit in the navigation section. The standard that we do with our practice is we hold chemotherapy 1 week prior to brachytherapy because we don't want the patient getting it the same week as brachytherapy in most circumstances. I will monitor the patient's labs beforehand, and if they're starting to dip really low, we will try to intervene. We do have resources for that to try to prevent them from having too low of counts where we have to cancel them, such as a really low neutrophil count, because of the risk of sepsis. So we will hold chemotherapy a week prior. We will monitor their labs, and if their white count, especially their absolute neutrophil count, is getting really low, say close to 1 or below 1, we will get them a colony stimulating factor, or their chemotherapy doctor will, to try to get their counts up, because we really want to try not to cancel these patients because their timeline is so critical for treatment to work. When they're with us, the other thing that we do for the actual treatment is they get IV antibiotics during the applicator needle insertion and during their hospital stay to minimize chance of infection. Dr. Shao, do you have any other
No, I think that pretty much covers all that we do as well. I think what in addition to that is just we while the patient is getting treatment, we always get labs before each procedure. So we always want to double check that they have adequate counts before we proceed. And if needed, transfusions are helpful. And if the white count is concerning, we will always get cultures too. Like Kayla presented at the very beginning of this presentation, for the GYN patients, there's data to suggest that completing treatment in a certain amount of time, which is 49 to 56 days, is very important. So our goal is to make sure that we meet that deadline. Otherwise, their outcomes could be worse. So preventive, I think thinking about these potential consequences ahead of time and anticipating that they can happen is very important.
Mm-hmm. And it's something, navigation for these patients, especially the role of nursing, can be a talk in itself. I have a few slides coming up about it, but it's kind of the core of what I do on our program. Is I do all of the navigation ahead of time, because it really can make a difference in minimizing chances of sepsis, getting patients optimized, and preventing case cancellations. All right, I'm going to keep us moving for the sake of time. So while variations will exist based on resources available, brachytherapy HDR patients will go through these 5 steps. Where they occur, what type of imaging is used will vary, but the procedure needs to happen. The imaging needs to happen for the treatment planning. The treatment planning needs to happen with the physician and the MD. And then the plan gets approved. They make sure that they're happy with how much radiation is going to the tumor or the treatment area, how much is going to the areas that they don't want to treat, making sure it's low enough. Then we actually deliver the treatment. Nursing care is required at each stage in this process. And then once all the treatments are complete, these applicators or needles will be removed. Implant removals can be another talk in its own. The role of nursing varies a lot, but the most important thing is with gynecologic brachytherapy implant removal, there's a chance for bleeding. The nurses will assist the physicians or whoever is removing it, but we have to be ready for bleeding, vaginal packing. Hemostatic matrices can be really helpful as well if they're available to help kind of topically stop as well, but we have to have everything ready and have sets of hands in case there is an advanced bleed happening. So this right here is the treatment itself being delivered with the afterloader, which is the machine with the arrow on the right. This is a prostate implant, and then the transfer tubes, which are the tubes that will connect each one of those plastic needles to the machine itself. That is how the treatment is delivered. So nurses as oncology navigators, this is what we just touched on. So for GYN in particular, good navigation is so critical. It is time consuming, but it makes all the difference for these patients if we can get them through treatment on time, minimize any logistical issues, minimize any issues with their labs, if we have the resources to be able to get them a blood transfusion if they're low from chemo, or get them a colony stimulating factor if their white count is low. Some places don't have this, but we could still help make sure if they're anxious and they keep canceling, getting them through that. The role of a nurse navigator is critical. Right now, this is my full-time job. I run our program, but most importantly, I, not just the operations for the program, but I navigate about 300 patients. And it is my passion to get these women and men treated on time, but especially the gynecologic patients, because it's so critical. We have for cervix patient, the current literature is, some literature says 56, historically has been 56 days for all treatment to be given, including external beam. But the new literature came out in the Embrace 2 trial that it's actually 49 days has even better outcomes. So we shoot to have all external beam plus brachytherapy done within 7 weeks. And it's tight, but it improves the treatment effectiveness. Laboratory counts, especially for patients that have been recently receiving chemo. Again, the nadir, when the counts dip the lowest after chemo, is often happening around the time of brachytherapy. And I will be having them get their labs checked the days prior to try to intervene so we don't cancel them. Pre-procedural diet and bowel prep, how to get their bowels and their stomachs cleared out for this procedure so we don't have bowel movements, so they don't aspirate. And so we can actually use a transrectal ultrasound to visualize they need a clean bowel. And then of course, medication hold, anti-coags, diabetic medications, GIP, GLP-1 receptor agonists like Ozempic or Wegovy or some of these medications that are being used for, those all have implications for anesthesia or procedures and need to be held. So nurse navigation is an exciting subspecialty. I gave an entire 90-minute lecture on this alone last year. This is a topic for another talk. There's so many details to cover and ways to organize this. So hopefully this will be provided soon. If anybody has any questions in this particularly, I'm happy to work with anybody one-on-one. This has been a tremendous area of career growth and empowerment for nurses. So guidance for radiation oncology departments wanting to implement procedures and anesthesia in their department. This is one of the other most common questions I get asked. How do we go from being a clinic to starting procedures, whether it's fiducials or hydrogels or brachytherapy? What do we do? And then how do you start incorporating anesthesia practices? So many departments do not have guidance for these transitions or appropriate policies and procedures in place, which can lead to unregulated practices, lack of staff confidence, lack of adherence to best practices, and can potentially jeopardize patient safety and satisfaction. So I actually developed, it feels silly to source myself, but this is what I'm presenting next week in Vienna at Estro. I developed what I call adopt, adapt, build methodology. It's so simple. It's painfully simple, but it helps people. Anytime a group will reach out and say, how do we know we're following the rules? What are the rules? We're oncology, we're not perioperative. How do we do this? I advise them to first adopt national and international best practices for procedures in perioperative areas. For nursing, this is the OR or anesthesia associations like AORN. There's so many, like there's one in Europe, there's one in Africa. For OR nurses, we can adapt that stuff to brachytherapy. There's a lot we don't need, but the core things are there. How do you position patients supine? How do you protect the ulnar nerve when they're asleep? How do you prevent blood clots in the OR? How do you have sterile fields? That stuff is published and it's international. That is the foundation that we can then take to brachytherapy and pull what we need. then adapt. A lot of hospitals, all hospitals, will have some sort of policy for their operating areas. Again, not brachytherapy specific, but we can review what each institution has and be asked to meet with those policy owners, meet with those managers, and asked to be incorporated in. I'm doing this right now at UCLA, getting us added to all the existing perioperative policies and having an addendum for radiation oncology. So for regulatory purposes, we are on policies. We can speak to these policies. We're under the umbrella, and all we had to do was ask them to adapt them to us, and then build what is unique to us, what is unique to brachytherapy, handling the applicators, sterilizing the applicators, radiation safety. This is where each radiation oncology brachytherapy team needs to identify what does not fit, adopt, or adapt, and then we build it ourselves, which is usually a handful of maybe a dozen or two policies. So support and structure can be provided to growing radiation oncology departments by utilizing these three methods. And nursing, and especially nursing leadership, must be part of this process, because what happens is radiation oncology departments don't have these. They just don't have policies. Everything is verbal. All the teaching is verbal, and that presents a significant safety risk, but it's a problem worldwide. And that's why I'm trying to start guiding groups to use this, and it's been working very well for us. Another most common question I get, what is the best way to clean instruments and supplies? I get asked this question from all over the world, and my answer is always going to be the same. We have to follow the instructions for use, or the IFUs, for each piece of equipment or instrument, which is provided by the manufacturer. There will be specific cleaning instructions for each item, taking into consideration the specifics of that item, the shape, the junctions, what is the material made out of. If we don't clean it based on the manufacturer's recommendations, it can damage it, it can cause infections, it really can be very dangerous. There are times where what they recommend to clean it is not possible due to resources, depending on the region of the world. That's where you have to be very careful. But the guidance is always to follow the instructions for use, line by line, to ensure that we are following infection prevention and safety protocols. This is also very important. I did a needs assessment on nurses. We got about 500 responses. And one of the biggest things brachytherapy nurses worldwide said was their greatest hardship, and this was very common in Africa, is they said they could not get a lot of applicants because people were afraid to work around radiation. They didn't, it was like an area they didn't want to be in because they didn't know if they could be safe in radiation oncology. And I always want to emphasize the importance of radiation safety training, because we can be very safe working around radiation, especially HDR brachytherapy. It's a common misconception that we are exposed to radiation when caring for these patients. When proper protocols are followed, this is false. And we wear dosimeters, we have vaults. If there's any concerns, of course, there's always breaches in this stuff, but as a science, as a discipline, you can safely work around HDR patients. And sometimes it just is staff education and getting word out that these patients are actually very safe to be around. Physicians, physicists, and RTTs especially can also be very helpful in promoting teaching this and reassuring people that we are okay to be around these patients. So there's always support. If you're starting procedures in radiation oncology, whether in a clinic or in a procedure suite, there are many teams and nurses available to speak with you and exchange ideas. And sometimes this simple networking exchange brings a significant amount of support. We are at time, so I'm going to just touch on a couple last slides. Brachytherapy patient education can be a talk in itself. Nurses are very important teachers for brachytherapy and in radiation oncology in general, because of side effects, because of preparation. And brachytherapy, of course, GYN especially is what I'm touching on the most. If we educate them, if we empower them, we can get them through their treatment and really try to get them onto other things in their life. Nurses in particular make a tremendous difference helping patients get through treatment. So one of the, again, so I will talk about, I know I keep repeating this, but we'll cover GYN. If people have if you have questions on other types of brachytherapy and what we teach them, please feel free to reach out. I'll put my email at the end, and we can guide you on that. So there's 5 big opportunities to train our brachytherapy patients at consults, but this is at consult where they're getting a lot of information. So I try to not give them too much. They've already spoken with the physician. They've learned about what they need to do. There's a lot in their head. So I touch on education a little bit, but I really focus on pre-procedure education where they've had time to digest the consultation. They're making preparations. That's when we teach them the prep, what to expect, and what to expect after. The day of procedure, there's also education, what to expect that day, teach the family as well if they're there or friends. And then post-procedure discharge instructions, how are they going to feel the next couple of days? What's normal? What's not? Who do they call? That's all done by nursing. And then ongoing or intermittent follow-up education as well. So I will keep moving. Consultation is just kind of the start. One of the biggest thing that's important is if they're having anesthesia or not, that will need to be incorporated into their education and what the institution's specific requirements are. Again, it will vary by procedure type, what we're teaching them. For vaginal cylinder only, it does not involve the use of anesthesia most of the time, so it's really pretty straightforward. And a lot of teams don't even require anticoagulation hold for a vaginal cylinder. If a tandem is being used, then they usually do. Fasting also, we don't require it, and bowel and diet prep, we don't require it, although we do ask that they have a bowel movement before they come. So vaginal cylinder education, a little bit more straightforward. What to expect afterwards, when to come back for their next treatment or their follow-up. Check with your physician on the plan for vaginal dilators or preventing vaginal adhesions and educate accordingly. We'll have a slide on this. Contact information for the team. Usually for vaginal cylinder only, we don't require antibiotics and because it doesn't puncture anything, although again, this can vary by physician. And patients may experience some dysuria as a side effect. Encourage hydration and limit spicy food or drinks. This does improve with time. For intracavitary with a tandem, which is the piece that goes up in the uterus, which is a little bit more painful, or if they have interstitial needles like this one, we will usually have them stop anticoagulation. Again, they're GIP, GLP-1 receptor agonists because these can cause delayed gastric emptying and aspiration during anesthesia. So it's very important that those get held. And then blood pressure, med hold, diabetes medication hold per institution or anesthesia guidelines. These patients will usually require a diet or bowel prep, fasting for anesthesia, and then we also want to discuss pain control prior to the procedure and what options are available to them, such as sedation or general anesthesia or spinal or epidural or other. Ways to promote comfort as well. I will tell the patient, bring something from home if they're staying overnight, whether it's their pillow that they like, not for in the OR, but when they get up to their hospital room, they can use their pillow, you know, like, or have a photo or their music playlist or just something to help provide comfort from a non-pharmacologic standpoint. After these patients go home from interstitial GYN treatment, we do tell them that they will likely experience light vaginal spotting, but bright red blood, bleeding, saturating more than a pad an hour is too much and they need to call. Dysuria can happen, or urinary frequency, burning or urgency, and slight discomfort. What is not normal, again, is vaginal bleeding that saturates more than a pad an hour, a fever, increasing pain. The pain should be getting better, not worse. Discharge that looks infected, abdominal distension, though rare. I have seen it before. We had a patient with a very deep tumor, very complex implant who did get a bowel perforation. And she had all of the classic signs of bowel perforation, such as abdominal distension. So that would be abnormal. And then, of course, inability to urinate or have a bowel movement. We also want to teach these patients good bowel regimen, especially if they're on narcotics or if they got anesthesia, they can get constipated and we don't want them pushing. So they can start to incorporate fiber back in, laxative if they get constipated, but they need to be staying ahead of their bowels. So dysuria is, it happens with pelvic radiation, whether it's external beam, whether it's brachytherapy. It is common after pelvic brachytherapy. And it usually gets better pretty quickly with time. Some patients it lasts a little bit longer, but as nurses, first we want to make sure they don't have signs of a urinary tract infection. If it's smelly, if it's cloudy, if they're trying to pee and they only go little bits at a time, those are signs of a UTI. We want to make sure they don't have a UTI. Most of the time, they don't have a UTI, but we don't want to forget and just assume it's from radiation. Once we know it's not a UTI, we can give them tips on managing dysuria, drinking water to encourage urination, and it also decreases the acidity of their urine, so it burns less because the pH changes because they're more and more hydrated. So we tell them lots of water. Avoid spicy or acidic foods or drinks such as coffee or berries or tomatoes or heavy spices until the burning improves. Then they can eat whatever they want, but that helps a lot. And then there are medications that can help as well to numb the urinary tract. One of the last slides is going to be on vaginal stenosis and adhesion prevention. So any patient who has received radiation to the pelvis, regardless if it was brachytherapy, external beam, if they receive treatment to the pelvis and they have a vagina, even if they got treated on their rectum, they need to have training and teaching to prevent vaginal stenosis and adhesions. Stenosis occurs when scar tissue makes the vagina narrower and shorter. And then adhesions is when the walls actually stick together. And this can cause pain during things like sexual intercourse, but also it can cause limited visibility during pelvic exams. And our physicians need to be able to assess for recurrence, assess what's going on. And we want the patients to not be really uncomfortable during it. So it has many purposes to prevent this. Both can be greatly decreased with appropriate interventions such as vaginal dilators or vaginal intercourse. Vaginal dilators, I have worked with a lot of nurses globally, and I find some countries do not even allow vaginal dilators. They are considered a sexual device, and they don't allow them for these patients to even be shipped into the country. So there are areas of the world that we have to teach them differently. But the important thing is that something is going in there, opening the walls of the vagina, and really trying to prevent this for these patients. Ongoing follow-up, depending on what we're treating them for, patients will have incremental follow-ups after radiation to evaluate how they're doing. Patients from farther away may have to have follow-up care established at home. It's just important that we keep tabs on these patients or know someone is. Some patients have difficulty maintaining regular follow-ups. This can be a significant barrier in regions of the world where access to radiation is much more limited. So ongoing efforts should be made to ensure that patients maintain their follow-up care, exams and imaging, and that any barriers be addressed as much as possible. As nurses, we can support our patients after treatment just as much as when they're on treatment, encouraging them, reassuring them, being available. I know our time is very stretched, but our presence is worth so much to patients, and we're often their main point of contact. Communication, answering their messages as quickly as we can, and following up with them even after treatment is complete. And then sexual health and appropriate referrals, anxiety treatment, because even if the patient, no matter what the stage of the disease, fear of recurrence is very real, and we have to take care of these patients holistically. Survivorship is just as important as care when they're on our treatment. And again, holistic care remains the backbone of our practice in radiation oncology nursing, not just for brachytherapy, but our whole discipline. So in summary, brachytherapy nursing is a tremendous field of oncology nursing. I had no idea when I started 7 years into my nursing career in 2012, I had no idea what brachytherapy was going to do or how much I would love it. It really is a tremendous field of nursing with an endless variety of skills, critical thinking, policy building. That's been new for me. And knowledge of various areas of medicine. Nurses can directly impact the patient experience, satisfaction, and quality of life during their course of treatment with or without brachy. And then brachy nurses can grow into leaders and even program managers. I had no idea I would one day lead the entire program for UCLA. I started as the bedside nurse, and every step has been amazing. And now I have the privilege of running the entire program. And nursing can do that, and that frees the physicians up to do their cases and grow their practices. And it's a collaboration. It's really neat. And brachytherapy itself, it's an incredible treatment modality, and it can greatly impact the care of patients with cancer and their outcomes. It is best practice for patients with cervical cancer in particular. They need brachytherapy for their best chance of cure. So if anybody has questions about brachytherapy nursing, how to adopt this into your practice, please feel free to reach out. We have an entire global network of brachytherapy nurses that we've been forming for the past 2 years. It started small and it just went crazy, and it's growing. Some photos from just the last year. We have members from 6 continents in this group now, from literally everywhere except Antarctica. It's pretty cool. And so just some different groups of nurses from Colombia to the ABS-GYN school to the World Congress to just all over the place. And this was only some of the photos that I had. So just loving connecting with nurses and connecting those nurses to each other, you know, as kind of being a conduit, but then also letting them form their own relationships and just connecting nurses with nurses. And, you know, I just got back from Italy. We had a photo that I don't have in here, just an incredible group of nurses from 7 countries that we all came together and exchanged ideas and taught each other stuff. And it was just fantastic. So there are people out there to be support and network collaborators with you. There are further ways to learn about brachytherapy, ABS, Gekestro or Gekestro, of course, this wonderful group, Rouse Contra Cancer, BioVentures for Global Health, networking with all of us. And then I'm very excited to announce and thank you to this course for allowing me to put this flyer up. I am leading a course with Brachytherapy, which is another nonprofit, and Aortic in brachytherapy nursing for GYN. It is specific for the continent of Africa. It is free of charge and it's open for registration now, due to launch June 15th. This is going to be a very intensive self-guided module-based curriculum. There's currently one out for physicians and physicists, but it's the first one ever for nurses, and it is free of charge. So please register. Again, it's region-based, so this one will be for anybody on the continent of Africa. If anybody has any inquiries or is interested in it and you don't live in Africa, please feel free to reach out to me and I can forward to Brachytherapy. Thank you so much for your time and dedication. My email is there below.